Good morning, everyone. Today I'll be covering the basics on use of GPS to reach the destination and its indication in ophthalmic plastic surgery. So during a surgery, what is actually GPS-based navigation-based surgeries? It is a computer-assisted navigation GPS system displays the position of the instruments inside the body onto a monitor similar to the GPS system in your car. It adds a favorable potential to the surgical armamentarium of an ophthalmic plastic surgeon and helps in planning the details in a three-dimensional virtual environment and execution with the real-time guidance in order to enhance the precision. So orbital surgery is technically challenging because of its complex three-dimensional 3D bony anatomy, crowding of the vital soft tissues in a closed narrow space, and of course difficult illumination in the posterior orbit. So providing the safest and the most accurate surgery with the least amount of manipulation and smallest incision has always been a challenge for ophthalmic plastic surgeons. To help with this, surgical navigation systems are now used to assist the surgeons, which have evolved over the years from the neurosurgical tool to maxillofacial and orbitofacial instrument. So data is preloaded into the computer in the form of CT or MRI, where we can see the fracture, tumor, foreign bodies, whatever we want to locate. And the software and the machine actually provides us with real-time updates in the form of intraoperative landmarks and to help us to reach the endpoint of the surgery. So in simpler words, just like a satellite provides the location coordinates to our GPS apps in map and the cars, and which helps us to reach the exact destination, this GPS guided system helps, with the help of the instrument, helps us reach the endpoint of the surgery in a very precise and accurate manner. So the armamentarium for intraoperative navigation involves the following components. First is the instrument console, which includes the instrument panel, display screen, and the operating software. The operating software includes planning and navigation mapping modules. The third is the patient tracker, which is mounted on the patient or on a clamp, like Mayfield neurosurgical clamp, that provides a stable tracking sensor. Just like in this image, you can see this is the tracker which has been mounted over the patient, and this stays like this during the entire surgery, and it can be mounted over a clamp like this for the stability during the surgery. And the fourth is the pointer sensor or the tracer, which is a handheld sensor used intraoperatively at the surgical site. So what are the preoperative steps that we need to do to add this into our surgery? That is, first we import data in the form of CT MRI. Then we select the procedure, whatever we want to do, that is the fractures, or we want to do the decompressions or the foreign body removal. And then comes the process of planning, that is registration planning and the post-procedure planning. So registration planning, for this, this is a video showing the registration of the patient's anatomy in real time over the CT MRI that we have already preloaded. Once the registration is complete, this anatomy of the patient coincides with the real-time anatomy of the patient and the CT scan. So once the registration is complete, whenever we point the tracer over the area we want to see, it will overlap with the CT and MRI and show us the exact anatomy where we actually are. So once this planning has been done and all the points are registered, we go for the procedure planning, which has two components, that is segmentation of the area of interest and the use of mirroring feature, which is a very unique feature in which we the normal side is mirrored upon the overlapped over the abnormal side, and from that we can measure the actual defect that needs to be corrected for a very precise and accurate correction. So this mirroring feature helps us guide that this is the exact defect that needs to be corrected. So once the mirroring feature is done, even angiography, MRI, CT, DCG can be merged with the CT scans using the merger software. So to sum up this, first we do the system setup, we do the validation and calibration of the tools, patient registration, and the navigation mode is activated. For technical accuracy, the CT scan slice thickness needs to be at least less than 3 mm, although these days we are doing up to 0.6 mm in our setup. And a number of factors influence the accuracy of the navigation system, including the imaging data resolution, registration precision, and computer algorithm accuracy. So what are the indications of this whole procedure? First, of course, it is the complex orbital fractures, as you can see. It is also used for surgical decompression in the thyroid or orbitopathy while doing the thyroid, when we need to know how much amount needs to be done and how much we have already done, and to pinpoint the exact location where the decompression would benefit the patient. Another very important indication is optic canal decompression, especially in complex orbital optic canal fractures, where we need to see where is the exact injury and what is the location where we need to decompress. Another important indication is orbital and apical foreign body extraction for location and tracing the exact location of the foreign body and avoiding the collateral damage when we take out the foreign body. Another indications are craniofacial with orbital deformity correction, especially in exorbitism that we see in the Cruzon syndrome. And of course, the endoscopic and lacrimal surgeries are also using this navigation procedure. So added advantages are that it is used to guide the surgeon in identification of the bony landmarks, especially in cases where the orbital as well as facial anatomy is distorted, in planning complex reconstructions and verifying adequate reconstructions and symmetry. It is also used in precise location of the tumors and its relation to the surrounding vessels and the nerves. And navigation guidance allows use of 3D image data of the patient to support the surgeon right from the diagnosis, operational planning, to intraoperative real-time guidance and verification of the reconstruction. So what are the scopes that we can use this navigation surgery in future, and which we are already using? That is patient-specific implants in repair of orbital wall fractures, and use of micro drills using navigation guidance in orbital decompression in thyroid orbitopathy, and 3D DCG guided navigation procedures while performing nasolacrimal surgeries. So this is the 3D printed model that has been developed using this software. And as you can see, we have made a patient-specific implant made to custom fit the orbital floor and the lateral wall fractures. So there are, of course, limitations of this procedure also, that is inaccuracy in the bilateral trauma, that when we do the mirroring, if the trauma is bilateral, then it will be a little inadequate guidance because of the mirroring cannot be adequate. And definitely not a substitute to the proper surgical technique and expertise. It is just an aid, a helping hand to the surgeon for precise results. Additional time is incurred in the preoperative planning, but it may be justified with better outcomes and minimizing the need for a revision surgery. Future advancements in orbital fracture repair are poised to make surgeries even more precise, minimally invasive, and personalized. That is like enhanced 3D and 4D imaging, artificial intelligence integration, and augmented reality in surgery. To summarize, intraoperative navigation is known by various terms: computer-assisted navigation surgery, image-guided orbital surgery, GPS-assisted navigation surgeries, and so on. Thus, the goal of the orbital and the lacrimal drainage reconstruction is to achieve complete and accurate restoration of the premorbid anatomy, which in turn lays the foundation for functional and eventually cosmetically acceptable results, maximizing outcomes with minimal complications. Thank you.
Thank you, Dr. Vatika. That was an excellent talk. Any question for Dr. Vatika? Any clarification or anyone would like to ask her, or we can keep the discussion at the end of all the talk?